Okay, great. Is that okay? Can you see that
Yes,
okay?
that has started.
Great. So, as Sigrun kindly introduced me, so you know all about me, I'm going to be speaking a bit about global aspects of pain management and then bring things around to EPM, essential pain management, that I think many of you will probably know about, but just to give it a global perspective. This is where I'm based, not actually in the castle, but down in Windsor. So I do apologise. We're right under the flight path of Heathrow and they're landing over us today. So sorry if there is any undue noise. You've heard about what I've done and what I do. Um, as I said, what I'm going to do, I'm going to say a little bit about why I think we need improved education in pain management from a global perspective, and then explain a bit more about what EPM is, essential pain management, talk about the history and growth of the work, and then think about what some of the future directions might be. So just to put some numbers on some of this, it's obviously very difficult to quantify the prevalence of pain, but if we think about it in three main categories, so acute pain, chronic non-cancer pain, and pain at the end of life. Just starting with acute pain, we know some statistics. So we know that around 50% of people have severe pain after surgery and trauma, and that globally around 10% of the world's deaths are due to injuries. And we also know that there's a big unmet need. So this has become quite topical over the last sort of 10 years or so. There's been a big Lancet Commission report and some work at the World Health Organization looking at the need for surgery. And there's an estimate that around 143 million more surgical procedures are needed, mostly, of course, in lower middle income countries, in order to meet that need. And that means that we also, or not only do we have a problem with acute pain at the moment, it's likely to get worse as we roll out that surgery. Moving on to chronic pain, again, as we all know, it's very difficult to quantify and to get sort of clear prevalence data on this for all sorts of reasons, which I won't go into. But across countries, actually, it seems remarkably constant, and the rates are roughly around sort of 20 to 30%. But as I'm sure you all know, difficult to really get clear figures on that. Uh, there actually is an awful lot more data when we look at things around palliative care from a global perspective. So there's been a lot of work globally, more than there has been in the other two areas. There's a lot of global work on palliative care and access to pain relief. And again, this is another piece of work from the Lancet, so another Lancet Commission looking at access to palliative care and pain relief. I just want to highlight really that because there is so much work that's gone on in this area, a lot of the work is skewed towards palliative care. So one of the things that it is important to remember is that the perspective comes from a palliative care background, and often it would be good to have a broader view really, with data looking at chronic pain, not non-cancer pain and acute pain. But looking at the data from this Lancet Commission, again, they are estimating that there is a huge unmet need for access to palliative care, around 60 million people in need. And again, 80% of those people being in low and middle income countries. Looking beyond prevalence, then, actually to treatment availability, again, there's some really stark figures. Around 5.5 billion people, so again, this 80% figure of the world's population are estimated to live without access to treatment for moderate to severe pain. And that's really mostly talking about access to controlled medicines and therefore access to opioids. That's where the big differences come in globally. To put that another way, of nearly 300 metric tons of morphine or morphine equivalent that is distributed a year, just zero point 0.1 of a ton goes to low income countries. Again, this is from that Lancet Commission report again, but these figures are very widely available. Every country in the world has to report their opioid consumption annually to the International Narcotics Control Board. And that means that you can get some quite interesting data out from people who collate the information. It's changed. There's been a group in America that's moved fairly recently, but I think you can still get some fairly good data from this bottom link here. And they try to collate data for different opioids and for different countries and different regions. And you can look at all those different variables and look at how they've changed. The graph I'm going to show you next is a little bit old, but there's no really major significant difference. It's hard to get these the data that I'm going to show you a comparative graph at the moment. So this graph shows total opioid consumption per year. So it's looking at not just morphine, but any opiate, and looking at morphine equivalents, and it's looking at per capita use. And you can see there's four different countries or regions here. There's United States, United Kingdom, the African region from the WHO, and the Southeast Asian region from the WHO. And the red line denotes the global mean of opioid consumption. And there's two really important things on this graph. Obviously, the thing that stands out to start with is the very, very high use in the United States, and we'll all hear a lot about that. I will touch on that briefly. That's what we tend to hear about is problems of overuse in high income countries, particularly North America. But probably the more important from a number of people who were affected by it is the African and the Southeast regions here, Southeast Asian regions here, which are almost unrecorded on this particular graph, on this comparative graph, because their use is just so tiny and so below what it really probably ought to be. So just very briefly, I think we hear a lot about overuse, and I'm not going to talk about that too much because I think we're probably all becoming very familiar with it. Things are quite controversial in some ways, particularly as to whether things that have happened in North America are going to happen in other countries. But I will therefore just quickly outline the problems. First of all, there's this issue around overzealous prescribing for the treatment of chronic non-cancer pain, and I think that has happened to an extent in many countries. The other two things I've got listed here, so multiple prescribers and direct marketing, those are really not so applicable to the UK. So it is just worth bearing in mind the differences when we hear about things that are going on in other countries. So first of all, multiple prescribers, obviously in the UK, everybody really is supposed to be registered with a GP or a family practitioner. And it's very difficult to get hold of opioids through other sources. Maybe possible, but it's pretty difficult. Certainly not very widespread. Whereas in North America and in the United States, it's very, very common, and it's really quite easy to do that. And also this issue that we've also heard a lot about from the pharmaceutical companies, so issues around direct marketing to patients. And any of you spent any time over in the United States, it's really quite extraordinary how much marketing goes directly to patients on the TVs and everywhere. So those are differences that we don't have, but of course they may happen in other countries, particularly in low-income countries. And as we also all know, there's been a lot of revised guidance, both at national and international level, looking at trying to alter practice around opioids and the use in chronic non-cancer pain. But what I want to talk about a little bit more, and just to make people more aware of, because I think we hear about it less, is this issue around underuse. This is a slide from that Lancet Commission that I mentioned about access to palliative care and pain relief. And it just shows again, with this quite interesting graphic, I think, the problem of distorted opioid use. So this shows opioid use or availability in countries with their land area distorted, of each country distorted in relation to the amount of opioid that is there. You can see here again, North America grossly swollen, Australia too looking large. Unfortunately, the countries that we're really most interested, or I'm most interested in, so that those of low middle income countries that we often tend to forget about, so Africa, South America, and a lot of Asia there, are almost imperceptible. They're very, very difficult to see. I think it's a shame that we didn't invert that graphic, and that we didn't have the bigger problem in terms of population being highlighted more. I think it just shows again how much we privileged the view of high income regions. Anyway, it's still, I think, a very useful graphic because it does show that the stark difference between what goes on in high and low income countries. So hopefully, just going to tell you a little bit more here about the low levels of use and why that happens. This is actually really not very contentious. It's pretty well described and has been described for quite a long time now. And there's three reasons that are often cited. So, firstly, we issues around education and a thing called opiophobia, and that's when people are very afraid of using opioids, even if they are relatively safe and tried and tested means of controlling pain. So, for example, for acute pain and pain at the end of life, people become very afraid of things like addiction, which is obviously not very common in those areas, or of severe respiratory depression. And of course, if you use the use opioids sensibly, and you're taught how to use them, then they are relatively safe in those scenarios. What happens is that because people then don't use them, they don't become confident, and as we all know, there is a skill to using opioids, and the dose ranges, do need a bit of education and a bit of knowledge and experience, and the less experience people have, the more frightened people are of using them. Tied into that are issues around policy. So there's often very, very stringent legislation. We have stringent legislation here, but we have systems that mean we can overcome those barriers, and we can work within a system that allows us to keep tabs on opioids, but still to use them. In many countries, that infrastructure just isn't there, and they err on the side of being overly stringent to prevent diversion, and people can become very frightened of using them, quite understandably. And doctors will risk imprisonment and severe legal sanctions if they get things wrong and are in possession of opioids without the right paperwork. So it does require a reasonable amount of resource, or certainly effort, to have a system that is workable but also stringent. So there's definitely issues around policy. And then finally, there's issues around medication availability. So, ironically, things like morphine can be incredibly cheap. But because they're so cheap, there often isn't an incentive to make them available. So you can get the unhelpful situation where, for example, a pharmaceutical company will make fentanyl patches available because it's worth their while putting in the effort to get through the legislation and to make fentanyl available in pharmacies, but because they're very expensive, people can't afford them. So essentially, that they're not available, and cheap medications, which they would be able to afford, are not there. So there's some real issues there around the actual medicine being present. And as I said, this is very well described. This has been talked about for many years, and there's lots to be read on that if you're interested. So I think I've shown that there's definitely a need for education, both in high and low income countries across the board. There's plenty of an awful lot of pain around, and there's an awful lot of problems in how we are treating it, with some very specific examples. So, essential pain management is one course that was set up in order to try to address some of these problems. It's an off-the-shelf package, a bit like other things I'm sure you're aware of, ALS and ATLS. PTC and SAFE are courses that are used more globally, often in lower middle income countries, but the same idea. They're all about these off-the-shelf packages ready to go, with materials and systems in place for us to improve healthcare. EPMs for all healthcare workers, and the idea is to improve knowledge around pain. And it's like ALS, we provide a simple framework. So we have an acronym like ABC, so that if you're faced with a problem you're not sure about how to deal with, you have a system to fall back on, so that you can go back to basics and make a sensible clinical decision. We also look at barriers to pain management. So that's something we tend to do more on the global level rather than in the UK work. And that's about looking at what other issues there are that are stopping effective pain management, and looking at opportunities about how we might be able to improve things. And that really ties in with making sure that the courses that we run are sustainable and are linked into good quality improvement work as well. So the format usually overseas, if we go to a new region for the first time, we try to get quick handover to the local teams as fast as we can. We tend to do what we call a 1-half-1 format. So we'll start with a one-day workshop, and that follows a fairly predictable format with lectures and lots of interactive discussions, case-based discussions for clinical cases, clinical scenarios, and then the barriers work that I explained. And then on the second day, we run a half-day instructors workshop workshop for some of the participants selected from the first day. And then on the third day, we do another one-day workshop with a new set of participants run by the newly trained instructors, often mentored by the instructors who were running things on day one. So we get a handover pretty quickly. We use this, the RAT system, which some of you will be familiar with, I'm sure. So we talk about the need to recognize, assess, and treat. And the reason that we use the RAT is because the idea is that rats are like pain, they are unpleasant, often unseen. You have to make a bit of effort to find them. But with pretty simple and cheap methods, you can very often treat things very well. Just to give a bit of an overview of some of the content, we talk about why we should treat pain, and we try to talk about broader issues rather than just the patient. So we try to make sure we're not just sticking with the physical medical stuff that we often limit ourselves to, and make sure that people think about the wider effects of untreated pain for families and wider society, and the costs that there may be associated with that. We encourage people to, as I said, assess pain. We will introduce all sorts of different methods of assessment. And obviously, as we all know, methods of assessing will vary very much depending on what patient you are dealing with. But also, of course, it will vary among different countries and different cultures. So we will introduce many methods, and obviously the course is designed to be flexible. And if people want to use their own scales and their own ways of assessing pain, we will very much encourage that and make sure that things are applicable to whatever environment and context we are in. Classification is one of the really important elements, and that harks back to what I was saying at the beginning of the talk. The reason we talk a lot about classification is because, of course, it affects the treatment treatments that are given. And going back to the opioid work, we very much do our classification based on whether treatments are effective or not. So we look at acute and chronic pain. We talk about cancer and non-cancer. Essentially, that means pain at the end of life or not. And we talk about nociceptive and neuropathic pain. When it comes to physiology, we have a lot of, this is our basic slide really, which shows the main steps that we think are necessary for people to know about, but we keep it flexible. So some people will be a bit bowled over by the amount of physiology and will probably switch off the minute we mention it and start showing pain pathways. So we do try to keep it simple in some ways so that we can, if necessary, just focus on the really important things. Obviously, it is important to make sure that people know about the complexity of pain pathways, that there are descending pathways, that a lot of things happen in the brain. And for some groups, if we're teaching anaesthetists, we can take things into a lot more detail if that's necessary. But we do aim to simplify it if necessary too, so we can alter how we use this slide so that you can tailor it really to your audience, and that's the important thing. And then finally, with the elements that we of the course, we talk, as I said, very clearly about treatments and making sure that the treatments are appropriate for the type of pain. This is a slide just looking at medications, but we talk about other treatments, of course, as well. This is just majoring on this issue around opioids and about both encouraging their use for acute pain and pain at the end of life, but discouraging their use for chronic non-cancer pain. So just trying to keep that message very simple, but making sure that both those things happen rather than just hearing that opioids are bad. We do want to encourage their use in certain scenarios. And as I said, we talk about pain management barriers, and we encourage local teams to be using their own knowledge and to encourage them to be working on their own initiatives and linking them into the education programme. This is just one of the examples. we use, and we this obviously is a 32-year-old man who's caught his hand in a machine. It's obviously an acute pain, and we will then take them through the RAT system. So how would you recognize it? How would you assess it? How would you treat it? And then once you've treated it, you can go back and start again and go round the RAT system. And you can see from this, you really could do all sorts of different levels of detail depending on who your audience is. You can take it at a very basic level, or you can take it through to the very specifics of how you would be prescribing and what you would do if certain treatments aren't effective. So just to look at EPM globally and how it's grown. This slide is a couple of years old now, but you can see even then there's been a really good spread. These are the courses that have been run all over the world in many different continents and many countries and different regions. It was originally written by Roger Gooke and Wayne Morris. So Roger's a pain specialist and Wayne an anaesthetist with the Australian and New Zealand College of Anaesthetists. And they wrote it originally to be used in low-income countries. They first ran it in Papua New Guinea, so very close to Australia, in 2010. But since then, it's spread, and we realised pretty quickly that it was actually useful for all regions. It wasn't just a low-income project. It was actually very applicable everywhere. It's been run, as I said, in over 55 countries, translated into many languages. We have a thing called eEPM, which is a really good resource if you're interested, and it's got lots of free modules, and you can go through and do a lot of the EPM content. It's often a good thing to do before you get people together to do some more interactive case-based discussion work. We have a steering group at the WFSA, so that's the World Federation of Societies of Anesthesiologists, which is the international umbrella body for national anesthesia societies. And as I'm sure some of you will know, we have an advisory group working on the UK stream of work at the Faculty of Pain Medicine at the college in London. Originally, we set up that group to coordinate UK instructors who were working overseas, but increasingly we have been working in the UK as well. We've run workshops in many countries across Africa and have mentored teams out in Pakistan, partnering with various charities and international organisations across the way. In the UK, and I can't really claim any credit for doing this work other than having chaired the group. Helen Makins was the original impetus behind this, and she set up the first EPM Lite. So that was just a half-day workshop without the barriers work down in Bristol, and we had a very flexible attitude to things then, and I think that's continued, and that I hope will come across if any of you, as more people get interested in EPM. We didn't try to push EPM to be done everywhere. If people had their own system and they wanted to keep working on that, that's fine. But if somebody did have a problem or say, look, we'd really love some resources, we really want to to use your stuff in order to run our pain training, then we thought, great, let's do EPM. And so, like I said, we just went for the low-hanging fruit wherever it was easy. And it's really grown. It's now called EPM UK, although I think there's a move globally just to use EPM now as the words, and not think about too many of the differences. A network of medical schools. We've worked with various other groups to try to get EPM recognized not as something that has to be done, but as something that is certainly noted as being a good course to do, and something that is often an example of good practice. So as I said, we started in medical schools, but actually we've run it to all sorts of different groups of trainees. So you can adapt it for core medical trainees, surgical trainees, anaesthetics, and GPs have also done the work. And the other way to do things, which is what we would normally do overseas, is to introduce EPM by institution. So that is by obviously usually a pain team will be doing their regular teaching sessions, and it's to embed EPM in that and to try to get hospitals to be using EPM as their standard teaching set of tools. And then everybody starts to have a common language. And this is back to what I was saying before about the flexibility we have. So there's a huge variety of delivery models. And, classically, EPM has been delivered as a one-day workshop. EPM UK has been delivered as a half-day workshop. But if people say, look, we've only got an hour, every couple of months, and that's all we can do, or we can only do things online, we'll say that's fine. There's no problem. Just cut up the course and run it in 4 modules over 4 different sessions, and you can just make it work for you. Or if you want to get people to do some work online, on their own beforehand, and then do online case discussions, and that's how it's going to work, then so be it. We're very, very flexible in whatever will work for you. We're happy to facilitate that. We have a team of regional leads, obviously your very own Naomi Scott, and thank you, Naomi, for getting in touch with me to do this talk, who's been leading on the work in Scotland, and we have leads all over the country who coordinate the work in those parts of the world. There's a lot of resources. It's really worth having a look on the EPM website, and also on the EPM, the original Australian New Zealand College of Anaesthetists website. So there's some example of modified slide sets, how you might modify them for your own use. Some more complex cases for anaesthetic trainees. E-Pain, of course, is available for people in the NHS. Some useful little videos about how to introduce EPM into an institution. And ideas about how you might want to tie in EPM to other learning objectives that are around about there. So whether that's to the curriculum for the college, or any other learning objectives that your individual teams may have. And just finally, I want to mention about evaluation and sustainability. These are often the things that we're asked about the most for all sorts of reasons. And interestingly, we're often asked about it more overseas, because when we're asking for money, we're often having to justify and to prove our worth. But we've done all sorts of different things to do our best with this, and we are forever evolving. In the UK, we pretty much always do multiple choice questions and get feedback from participants and instructors in various methods, whichever is deemed most appropriate. We've also done some work overseas with staged MCQs, so that's looking at how things have changed over 3 or 6 months after a workshop has been run. And we've got qualitative data from interviews with key informants. Things called a commitment to change, that's looking at asking people how they think their practice is going to change, or how their practice has changed. And then linking things in, as I said, more with the barriers work, trying to link things in a bit more with clinical audit and service improvement issues, even if it's just looking about recording pain scores and just starting to raise awareness. But this is always something, it's a bit of an ongoing thing for us. I think we have to all be prepared to accept that we're never going to get the actual gold standard in this. We're always going to be striving to improve. But I think just because we can't get a gold standard doesn't mean to say we shouldn't be working on this. So it's always something to bear in mind. And I think often for me, some of the most interesting work that we get involved in. So in summary, I think I've shown that there's definitely a need for improved education in pain management at a global level. EPM, Essential Pain Management, is a tried and tested model with increasing popularity in a huge variety of settings. Really is high income, low income, all healthcare workers. And adaptability and sustainability for us always remain priorities in whatever environment we're working in. These are some resources, and I hope there'll be time for questions.
That was great. Thank you, Claire. We do have some questions, and I probably also have some questions as well, because I get the mic, so I'm able to ask things as well. I think we do definitely need more training, don't we? So it's great to have something that starts to give people more information, given how limited often knowledge is out there. We do have some questions from the delegates. So we had a question: was there MDT input in the development of the training? Who's sort of involved in it?
Yeah, that's a good point, actually. It was only written by 2 doctors. There are obviously many other people who've been involved in the work. It does we always train people from any cadre, and we immediately get people, certainly overseas, we get people involved from any as trainers from from any team if they are
So
happy
does
to
it
do
tend to
it.
be medics that deliver it, or?
Often to start with, because usually they, not exclusively, I would say, in my experience, they are the people who are likely to be leading on things. Um,
Yeah.
and I think there are, um, I think that the situation we have in this country is not replicated in lower income countries. It is the hierarchy is really, really strict. I mean, this is a gross, simplification, generalization, but I think there's definitely more pronounced, and pain services are not places don't have an acute pain service. Where I would have worked in this country, the pain nurses did everything, and they would set up the teaching and they would do, and they just had it and it ran with it. That's rare. Um,
Mhm.
Things like that are usually initiated by doctors, but definitely with other teams involved once things get going.
Yeah. We had another question which was, do you include any further assessment on things like function or quality of life or things like
Yeah,
that?
yeah,
Obviously,
very much so. Yeah, absolutely. I mean, I only picked out a couple of slides here. They're freely available. The slides for the actual workshop here, so you can have a look through. And that maybe the app is on here, but there
I'll
is an
try.
app, and there is, as I said, the EEPM is very easy to find through these links, and you can find more information about that. But yeah, absolutely. And in fact, we're very, very on the treatment. I mean, I majored on opiates because that's an interest of mine, but also the big issue that's there at the moment. But we put a huge emphasis on making sure that we don't talk about physical medical treatments first, that we talk about non-medical treatments because
Yeah,
that's what always gets left behind. So yeah, yeah.
yeah. And Katrina was asking, will there be some updates seeing some more sort of outdated terms on it, given changes in recommendations around short-acting opioids and surgery and long-term pain? And breakthrough was in the teaching as well as no mention of functional pain scoring rather than numerical.
There is. I mean, we do talk about functional pain scores in it. I mean, like I said, this is, I mean, and we have we have stuff on functional pain scores. It's just, as I said, the slides that I'm showing you. I'm only showing you a very brief number of them. Um, the point is that we have to be very flexible, and functional pain scores are really useful, and that's something that we are using increasingly, I think. Certainly when I finished work we were using them more, but we haven't always used them and as I understand it, and different people, things are done differently in different places. So it's the main and most important thing from our slides is that you can adapt them to what is most appropriate for you, rather than us saying you must use functional pain scores. We would introduce that concept, but the idea of EPM is to give people a system that they can then go and do their own most appropriate local teaching on. We are not trying to say you must use this score, just if that makes sense.
Yeah.
And similarly, what was the first bit of your question?
Will there be some updates of seeing some
Updates.
more outdated?
Yeah, I mean that we do obviously always update things, and there's things on nociplastic pain and things. Um, we again, as I said, we try to teach principles in this course. So the issues around opioids, as I understand them, are around the principles, rather than saying this is the opioid you use. I mean, in low income countries, long-acting opioids are just not really a thing. But obviously we would always encourage the use of short-acting opioids. We wouldn't have had long-acting opioids in this anyway. But any of these discussion points will come up, and if they come up, you can adapt the issues to whatever you're dealing with in your environment.
I think certainly it's good to have a starting point for people.
Exactly.
There's such poor training in terms of pain management. Even in this country, I think it seems still to be
Absolutely.
very limited, and to have something to start from, I think at least gives some sort of structure around it.
Yes, and
Um,
I think in my experience, people often get caught up with the details. They say, God, how do we use fentanyl patches? Or how do we use, oxycodone? And how do we OxyContin? And actually what people really often need is to go right back to first principles and say, look, what are you actually trying to treat here? And what do you want? You want a short-acting opioid, right? This is the choice you've got. And, I think we get caught up with the complexities of the number of formulations that we have rather than really going back. That's just my experience.
yeah, thank you very much. Does anybody else have any questions, or anybody from the committee have any things they want to chip in before we carry on? Because we're
There's a
doing quite
hand
well.
up. Steve's got his hand up.
I can't see Steve's hand up. Go for it, Steve.
Hi there. Yeah, the controls of Zoom are very tricky, aren't they? I wondered, Claire, I was involved in delivering EPM, and yeah, that idea of a half-day education for medical students in the UK, where it's really designed for developing countries and low middle income countries. Do you think there's a danger that if we deliver this essential pain management, that the medical schools will then say we've ticked the box, we've given some information about pain management, and it will prevent more in-depth and what we would hope would be the standard of pain management education for medical students and other healthcare students?
Um, I I don't know. I mean, I hear your point. I mean, that's true of anything, isn't it? Of any course, I guess, of anything we're doing. EPM was only ever designed to be the opener, really. Um, I don't know. Are we going to be treating resuscitation worse because everyone does ALS? Hard to argue that. Um, I think it's up to us to say this is just the starting point, isn't it? And I don't think we are I think we have to be realistic that we aren't massively better than the lower middle income countries. As you said, my experience is that it's the basics that people are not good at. I don't think, personally, from when I was working here, I thought that the bigger gains would be made by getting more basic training across to more people rather than focusing on more high-end teaching strategies personally. But that's
Yeah,
just
I
my.
think there's a point to that as well that, we've been in pain management for many years and got lots of knowledge and we think, oh, that's fairly basic and sometimes pitch things too high for medical students. But yeah, certainly looking at medical schools' willingness to put pain management into their courses, there's always this objection that the curriculum's already full.
Yes, always, always, always. I
Keep
mean,
people.
and there is that paradox, isn't there, with all of the pain stuff, is the more we say how important it is, to have special pain teaching and special pain doctors, that the more and pain teams, the more people say, oh well, that's pain, that's not our problem, that's the pain teams, and there is that paradox there always, I think, about putting things in a box and then making it somebody else's problem. But
I
Thanks,
think
Joanne.
I think Chris has a question.
Yes, I do. I do. I'm just doing a little bit of work in the background, but
Sorry, putting you on the spot, Chris.
that's grand. Thank you, Claire, for that really insightful talk. I think the most impactful slide was the one of the globe that you shared, and I do like your idea of sort of flipping that to really reveal some of those inadequacies. I've got a couple of questions actually. The first one is about culture, and you mentioned 80% of people affected by moderate to severe pain do not have access to pain management services. So what, therefore, are some of the cultural norms to manage pain that you've encountered in the places you've worked in? And actually, can we learn from that rather than the other way around?
I think it's a really interesting question, and that's one of the things I noticed most when I was doing my research was this what I would call a medicalization of pain, and I think I think it's a bit like the opioid graphs. I think there are two issues. I think there is often still an undertreatment of acute pain, and pain at the end of life that really is. And we just forget how easy it is to treat some of these pains because we just do it all the time. But I think there is the converse to that is and an increasing, and I would say worrying, issue around medicalization of chronic non-cancer pain, which is largely uncurable by definition. There are ways we can help people to manage it, but we do not have the solutions. And I think there is a potential problem with us sort of saying, oh, we need to get more pain treatment out there. But I think we need to be realistic about what we can and can't do, and that there's definitely examples of people who would never have considered their pain as something that is a medical problem, but increasingly we are encouraging that to be the case. And I think we have to be very careful about being realistic and very open about what medicine can achieve. And I think that's what's happened with the opioid crisis, is we are not prepared enough to look at those limitations of what we are able to achieve.
And I think my other question was, you mentioned that prevalence of addiction to opioids just doesn't exist purely because the various reasons that you gave in again these low to middle income countries, and we know addiction is a bit of a universal.
Oh no, addiction happens. Addiction definitely happens.
Yeah. And I think my question was, okay, if there's not the issue with opioids, is there like a dominant sort of pattern towards addiction, and what does that look like if it's?
I mean, no, there are opioids, and there are opioids. People are addicted to opioids, and people get opium, and you go to certain countries, and you can actually get illicit stuff easily. What I was meaning to say at that point, what I was meaning there is that opioids, you can get addicted to opioids, as we all know, but you are not very likely to get addicted to them if we use them in acute pain setting, if you know what you're doing with them and you stop them at the right time and all the rest of it. It is relatively unlikely, and certainly obviously at the end of life, because that is again an acute pain setting, if your use is going to be very limited. The message we should be sending out is not that you will not get addicted, but that it is unlikely in this setting if you use them in this way. I think there are issues around people in the past having said you won't get addicted to them, and then people don't believe that, because they have examples of people who've been addicted to pethidine or or things. So it's more nuanced than that. What the point I was trying to make was that people are worried about addiction all the time for giving any amount of opioid for any what you would consider, I think, probably very really reasonable use.
No, that's fair. That does. Yeah, thank you for the clarity.
But everybody is people are worried about addiction in a unnuanced way, I would say.
Yeah,
if that makes sense.
It does. Yeah, good answer. Thank you.
Lynn, you've got a question.
Thanks very much, Sigrun. Yes, it was probably more just a comment. Thanks so much, Claire, for that overview of what's going on. It's incredibly helpful. I guess what I just wanted to comment on is that obviously within Scotland nationally, there has been an awful lot of work done around multidisciplinary education, and there are modules available that have been compiled through NESS and a group, and we're now starting to look at the more in-depth modules. And I guess it would just be, it's such a shame that we can't kind of join things up a little bit more. It still maybe feels as if it's a bit kind of medical and then multidisciplinary, but it's maybe something to think about for the future. But it's a fantastic resource. Thank you.
We do always, I'm really pleased you brought that up. We do often bring that up in our meetings. My work is the global work on this now, but people often do bring this up. Naomi, if you want to if there's a nice volunteer who would like to come down to our EPM advisory group. We very welcome if anyone. So I can leave that with you, or maybe I can chat to Naomi about it afterwards. But we are very willing to liaise more, and we would love to. But obviously, because we're based in the college, we tend to have a medical centric view, but we are very aware of that, and we would like not to.
Perfect. Thanks, Claire.
Naomi.
Hi, I don't have the power of turning my own video on, it seems, but yeah, I just wanted to comment on what you said, Lynn, that, oh yeah, I can start my video, excellent. The modules that were created recently, we did incorporate essential pain management, as Claire said, it's just so flexible. But also we have used it in multiple settings, so to train some of our first contact physiotherapists. It's just a great tool, and it's so easy to adapt. But I think you're right. You do need people who know how it needs to be adapted to be involved. So yeah, I think I don't think it's overly medical, as long as it's in the right hands and delivered in the right way. And it is incorporated, as I said, into some of these modules that have just been released by NES.
Great. Thank you so